Good afternoon. My name is Terry Wilt, and I'm the Director of Community Engagement for Mayo Clinic Health System in Southwest Wisconsin. On behalf of our entire organization, I want to welcome you to today's community forum, Ending the Pandemic of Misinformation and Misperception. This is our fifth community forum devoted to COVID-19 topics. Each forum is intended to address your most pressing questions and concerns as we travel this COVID-19 journey together. Along the way, we've shared the latest information on the COVID-19 virus, including testing, treatments, vaccines, and variants. Today, we continue our quest to bring you current and reliable information to help you make informed decisions. Last year, as COVID-19 spread around the globe, doctors and scientists began conducting research and sharing their evolving knowledge of the virus. At the same time, unverified information and sometimes false information began appearing on social media and other outlets. With the resulting confusion came divisions that seemingly placed people on one side or another. Yet as the Delta variant fuels the spread of COVID-19, misinformation inhibits progress toward bringing the virus under control. Today, we hope to reduce COVID-19 misperceptions and lay to rest some popular misconceptions. To that end, we're very pleased to have with us today one of the world's foremost infectious disease experts, Dr. Gregory Poland. Dr. Poland is director of Mayo Clinic's Vaccine Research Center and a leading voice on the scientific evidence supporting the benefit of COVID-19 vaccines. Dr. Poland studies the immunogenics of vaccine response in adults and children. He's chaired or served on every federal committee involved in vaccine decision-making, including the National Vaccine Advisory Committee and the Advisory Committee on Immunization Practices. He's regularly featured in national news stories by NBC News, USA Today, Business Insider, and others. He is in high demand as an advisor and a speaker, and we're truly fortunate to have him with us today to share his knowledge and answer your questions. We invite those of you attending via Zoom to submit questions anytime during the presentation using the Q&A function. Due to the volume of questions received before and during the forum, we won't be able to address them all, but we'll get to as many as possible later in the program. And now to begin our discussion, we turn to Dr. Paul Mueller, Regional Vice President for Mayo Clinic Health System in Southwest Wisconsin. Dr. Mueller is a professor of medicine and a professor of biomedical ethics in the Mayo Clinic College of Medicine and Science. He's also been recognized as a top internist by US News and World Report and has authored or co-authored more than 130 peer-reviewed publications and hundreds of book chapters, abstracts, and columns. Dr. Mueller, I turn it over to you.
Well, thanks, Terry, and welcome everyone today. We have a large number of people who've signed up for this very important session to hear the leading expert on vaccines in our nation and perhaps the world, Dr. Greg Poland. Next slide. Just a few introductory comments. Right now, the pandemic in its current state shows wide community transmission of the virus. This is a heat map provided by the CDC, and it shows that by and large, most of the country is red. So community spread is quite wide right now. On the right-hand side, you see the number of cases being reported daily. And the lines are 50,000 each. So we're having a large surge of cases recently that's mirroring what we experienced last fall. Below that are the number of deaths. And you can see it's practically a mirror image. While the numbers are lower, they're numbering in the 1,000 or more per day. That's what makes this current surge so difficult. Next slide. So what are the features of this surge and why is it different? The highly contagious Delta variant now accounts for virtually 99% of cases, whereas it was less than 1% in May. Most hospitalizations and death due to COVID are comprised of unvaccinated persons. While health systems have adequate PPE and robust safety protocols and are dealing with a surge, staff fatigue and shortages are prevalent nationwide. In addition, health systems are busy with non-COVID patients and hospitals, by and large, are full, including here in the Midwest. This surge followed a period of relative calm, but is concurrent with school openings, business openings, and other activities where people are getting together. And public health guidance has been mixed. What also makes this surge different is the fact that we have vaccines. The efficacy is clear, and you'll hear about that from Dr. Poland. We have FDA approval, boosters are now being given and for recommended individuals, and mandates are now more common. And you heard the statement from the president yesterday. On the horizon, there'll be vaccines for children younger than age 12. We're also hearing more expressions of frustration from vaccinated people regarding the unvaccinated. That's just a simple observation. Next slide. So widespread vaccination is our best hope, and we're seeing progress worldwide. This is an article that was in the La Crosse Tribune that we published last August. But it's my pleasure to really turn this presentation over to the expert on the topic, Dr. Greg Poland. He's not only an exemplary researcher with highest level National Institute of Health funding, he's an outstanding physician and teacher and a close friend of mine. He has the highest level of integrity and is a man of deep faith, is actually studying in the seminary right now. He, in fact, is one of the finest human beings that I know, and I'm very proud to bring him to this audience. Please welcome Dr. Poland.
Paul, thank you so much for that nice introduction. I have to say, in Rochester, we miss you. Paul was my division chief and really enjoyed working with him and interacting. I miss you, brother.
Thank you.
Let me get my slides up here and we will get going. So I've been asked to address this, and I will. One of the ways that I'm going to do it is by going through a fair amount of information fairly quickly. So if you'll, do your best to sort of keep up so that we can get through this, because I think it will answer a lot of questions. Just disclosures, I could basically summarize it by saying I give consultative advice to virtually every vaccine manufacturer, at least in the West. So I'm going to start by talking about the nature of reality and the lies that we tell ourselves. The reality is that the story of this pandemic will depend upon two things: human behavior and viral behavior. Note that we only get to control the first factor, although it, of course, influences the second. As one person said about a different topic, we've met the enemy and he is us. That is to say, we voluntarily gave up control of this pandemic. And a key skill I'm going to ask you to work with me together as we go through this is separating fact from fiction. In fact, your life and those of your loved ones depend upon this key skill. And unavoidably here, we're flying the airplane as we build it. I'm often asked, well, what is going to happen 10 years from now? I have no idea. I don't have a crystal ball. I can't even see to an hour from now. And that's the nature of science. And yet, we have to make decisions in the midst of this raging pandemic in order to decrease deaths, hospitalizations, complications. As Dr. Mueller mentioned, the tremendous surge demand on the medical system and the toll that takes on physicians, other providers, and patients. We have to protect ourselves and others, many who cannot protect themselves. And I think it's a sobering statistic to say that had we stood Christmas of 2019 at one edge of the country, and if we could have looked out over the whole country, to say that a mere 18 months from now, 1 out of every 490 Americans would be dead of COVID, I think we would have reacted in hopefully a very different way. Well, one of the things, again, as Dr. Mueller alluded to, that's really driven this fourth surge is the Delta variant. It's extraordinarily transmissible, a reproductive rate of 5 to 9. What that means is that if I were to get infected, on average, I would spread it to 5 to 9 other people. One of the things we're seeing is a lot of children and younger adolescents get infected and sick from this, something we did not see, or at least uncommonly saw, with the ancestral Wuhan strain. Part of that is this highly transmissible variant and the fact that it leads to significantly higher viral loads. In fact, the estimate is that the amount of virus in the body is 1,000 to 1,200 times higher than the original strain. And that allows for some level, there's scientific controversy over just how much, evasion of both vaccine-induced and convalescent immunity. Convalescent immunity being you got previously infected, and yet you may not be protected in the face of this variant. So it's been characterized in children as this is happening quick and they get sick fast. There's been, as I said, a significant increase. In fact, it is now exponential in the number of children and adolescents who have been hospitalized. In other words, sick enough to be hospitalized. In the last week, it's been 27% of all new cases. Again, a stunning number that we didn't see anything like this in the beginning of the pandemic. There were 250,000 new cases last week in children and adolescents. There were almost 2,400 children hospitalized in the US with COVID-19, which was a 27% increase. And thus far, very unfortunately, about 529 kids that can be accounted for have died now of COVID-19. If you look at population risks on the top graph, and this was really before Delta, but I just barely make it into the 65 and above category. So I'll just choose myself. If I were unvaccinated, my risk of being hospitalized compared to a healthy 18 to 29-year-old would be 6 times higher than that person. And my risk of death would be 95 times higher. So this is a significant public health issue. And remarkably, though there are ears to hear and eyes to see, people have turned a blind eye, a deaf ear, if you will, to this information. We have about 30% of American adults who say there are no circumstances under which they would accept a vaccine. A really remarkable thing to even imagine happening in a country that has more literacy, more money, more health than any population in the history of mankind. Again, before Delta, if you were unvaccinated in the US, you're about 5 times more likely overall, this is everybody, to get infected, 29 times more likely to be hospitalized, and much more likely to develop and have to live with so-called long-haul symptoms. Now, just a few studies. There's a lot of detail here, but I'm going to point you to the major points here. If you look between round 12 of a UK study, so this was from the 20th of May to 7th of June, versus the next week that they looked at, the 24th of June to the 12th of July, okay? A lot of people in these studies that get swabbed every week. In the 13th round, the 527 positives, or 0.63 for the overall population, 4 times higher than round 12. A 3-fold reduction of infection among the vaccinated versus the unvaccinated, 0.4 versus 1.2. Interestingly enough, because you do see different data with different study designs in different geographic locations, here the viral titer was slightly lower in the vaccinated versus the unvaccinated. I know it looks like I said that backwards, but I didn't. These CT values, it's a bit like golf. The lower the number in this case, the higher the viral titer. If you look at the HEROES Recover study, this is primarily a study happening down in the Southwest. when they looked between December and April, again before Delta, so these would be different. They're following about 4,000 people over a 13-week time period. All the cases they saw were among the unvaccinated, with the exception of 5 that occurred in fully vaccinated, 11 in partially. This is the key point. If you looked at vaccinated workers who nonetheless had, quote, breakthrough disease, they had a 40% lower viral load, a 66% lower risk of detecting that virus for more than a week, almost a 60% lower risk of fever symptoms, and what symptoms they did have subsided about a week earlier. Now, the Singapore multi-center study. Here they found that viral loads, and this has been picked up on by the media, were similar between the vaccinated and unvaccinated, and people don't really know how to understand or think about that. The key thing is that those viral loads very rapidly declined in the vaccinated group versus the unvaccinated. More important is the graph that I show below. So these are the outcomes of disease in unvaccinated people, in Singapore, and vaccinated. So about 1.5% of them died. None of the vaccinated people died. About 5.5% of them ended up in the medical ICU. None of the vaccinated. About 21% needed supplemental oxygen. About 3% in the vaccinated. 53% developed pneumonia among the unvaccinated. About 22% in the vaccinated. So quite a difference in complication rates and intensity of medical need. Well, this leads to what I've called the need for a robust epistemology. In other words, what is the interpretive lens you use to determine truth? Now, arguably, this is SARS-CoV-2 and this pandemic is a science problem, a medical problem. So if you abandon science as a way to determine truth, you enter into a world of hurt, as we have seen case after case after case in the media of people who reject vaccines for very ill-formed and uninformed reasons, and suffer devastating consequences as a result. So the major distorting factor turns out to be human behavior. Vaccine hesitancy and rejection, being against masks, political and economic conflicts of interest, lack of leadership and fear, the false presupposition of the democratization of expertise. In other words, the idea that everybody's a scientist and everybody's ideas about science are equally valid. Well, that's just not how science works, thankfully. A false epistemology, as I've described, and we have to realize that we live in a culture that's narcissistic. In fact, it takes people aback sometimes when I mention this, because we are very much in a me rather than a we society. That's not true in other societies, particularly in Asia, where young, healthy people routinely wear masks to protect others. That would be an uncommon phenomenon in our culture, as we've seen. When you look at vaccine hesitancy, I think it's shocking to realize that we are just below Russia and their government in terms of people trusting the scientific information they receive. And those vaccine hesitancy issues range from hesitancy to outright rejection. By the way, that has happened in the same proportion with every vaccine ever released in the US since the very first vaccine, smallpox, in the 18th century. For those that are interested, I published a review article in the New England Journal in 2011 on this. But they range from legitimate concerns and questions to conspiratorial type thinking to low complexity cognitive thinking. That's the magnets and nanochips and bots and things like that. Bandwagoning, which you can think of as peer pressure, fear-based decision-making, heuristic thinking, which are shortcut rules of thumb people use in their thinking that always misleads them, and magical thinking. Good example of that was the famous phrase, "One day we're going to wake up and this will just simply be gone." That's magical thinking. And then other motivations. My daughter and I and a designer at Mayo Clinic published this paper just a few months ago in March, looking at how we might improve vaccine acceptance. And they introduced a novel tool called the empathy tool to help people in their journey of moving from a false interpretive lens to a science-based interpretive lens or medical-based when it comes to their health. But one of the things we started the paper with is something that psychologists have known for a long time called belief-dependent realism. And the bottom line of that is people form beliefs before they even have the data, and then they accept the explanations that support their belief and reject those that don't. So if you look, we form our beliefs for a variety, and look at the types. None of those are data. In the context of environments created by, look at that list, none of it is science. After forming our beliefs, we defend, justify, and rationalize them. And that's one of the phenomena that's driving this. And because of it, we gave up, as I mentioned, the ability to control this pandemic. So one of those issues that is very hard for people to understand is the issue of exponentiality. Humans always, without exception, miss exponentiality. They want to, quote, wait and see what happens before they take, a bold step, for example. So let me just take you through this. Let's take scenario A. Closer, the reproductive rate was probably a little lower than this, but about what we saw in the beginning of the pandemic. So one person gets infected, 10 cycles of transmission in a naive population, which we are or were, that would lead to about 9,500 infections. Okay. Now let's move to today, scenario B, where that reproductive rate is somewhere between 6 and 9. So I chose the lower, more conservative number, 6. After 10 cycles of transmission, you don't have 9,500 infections. You have over 60 million infections. And that's why I call it, and exponentiality happens in wildfires, for example. People have no real concept. They miss each time what's going to happen with a fire like this. They become raging fires that are out of control. And you see that in the entrance of the Delta variant in the US. On the left side, July 5th, you saw a relatively few number of counties in the US that had substantial or high transmission. Just a month later, you see that something, and it's actually now something like 99% of counties have substantial or high community transmission. It happened that quickly. So the truth is that there is no one modality in and of itself sufficient to end the pandemic. Rather, like an onion, it's layers of mitigation, because there is no man-made product made for any reason that's 100% effective. So it starts, the core of the onion, if you will, is now with the vaccine. And everybody who doesn't have a contraindication should receive that vaccine. Then masking when we're indoors or in crowded outdoor venues. Appropriate distancing, and perhaps for some people under certain conditions, monoclonal antibodies. Because we gave that up this summer, because we stopped doing that when we had reached a real nadir in cases, we have seen the continual evolution of viral variants, some of which have already developed the ability to escape in part both vaccine-induced and convalescent immunity. So it boils down to this, for all of you that can hear me, you get to choose which risk you want. That ignores the risks for other people, but that's the society we live in. And you only get 3 choices, whether you make a choice or not. You are adopting one of three choices. Either you will get infected, and if you are not vaccinated or previously infected, and we'll come back to that, you will get infected. And if you survive it, perhaps have some of the consequences. Or you'll get vaccinated, or you'll go into complete and total isolation, like Howard Hughes, which has its own set of complications and risks. So let's talk about vaccine safety. And as I said, there is no such thing as safe. Abandon that from your vocabulary. There is no human product perfectly safe, and there never will be. There is only safer. Wisdom resides in being able to look dispassionately at the balance of risks and benefits and choosing those that most benefit you and those around you. So let's start with vaccines. I've been a vaccinologist for 4 decades. No vaccine has ever been studied to this degree and with this degree of rigor and scrutiny prior to release. And yet I'll be the first to say, we will never know all that we wish to know. We have had influenza vaccines for 7 or 8 decades. As we're talking, studies on yet newer and better flu vaccines are taking place. The reason for it is that the science always evolves. And therefore, decisions about vaccines and about public health policy have to involve a consideration of the known, let me emphasize the next word, data-based risks and benefits at the time that you have to make the decision. You can't wait to make many of these decisions. So let me look at side effects. This is where a lot of people get hung up. This is where fear-based decision-making occurs. Do harms come from vaccines? Yes. Do they exceed those of not getting vaccines? A definitive no. So let's look at some examples. These are, the top is the Johnson & Johnson vaccine, the bottom, the 2 mRNA vaccines. So let's take myocarditis as an example. That's been in the news a lot. We can pick, whatever we want. We'll start with a female. Okay, the highest risk is of myocarditis, inflammation of the heart, is in females 18 to 29 from the vaccine. All right, if we didn't give them the vaccine, there'd be just under 13,000 cases out of 1 million. These are per million, all these statistics. If we didn't, or rather, if we give them vaccine, here's what happens. We prevent 750 hospitalizations, 50 ICU admissions, and 5 deaths. Or 3 to 4 cases of myocarditis, which is generally minimally symptomatic, resolves in a few days, usually doesn't require any treatment. Which risk do you want? You have to choose one of these. Whether you choose or not, you are choosing one of these. Let's take males. The highest risk is in the 18 to 29-year-olds. About, let's just pick a middle number, 25 develop myocarditis. If we don't give vaccine, just under 10,000 will become infected. If we give vaccines, we will prevent 300 hospitalizations, 60 ICU admissions, and 3 deaths. So we are always weighing risk and benefit. No vaccine is 100% safe, but choosing not to get vaccinated is far less safe. And so which risk are you going to accept? Well, who gets breakthrough disease and what does it mean? I think for lay people, this caught them by surprise. Every disease that we vaccinate against has breakthrough disease. We have never discovered a vaccine that is 100% effective, never wanes in immunity and where there's no breakthrough disease. We expect that. So what does it mean? Well, let's just give an example. This happens to be the Moderna trial. So when they did the trial to look at the efficacy of the vaccine, as they gave the 2 doses of vaccine among the group that got the mRNA vaccine, this blue line here, you see this tiny accumulation of cases. That's breakthrough disease. If you look at people who chose not to, or in this case were randomized to the placebo group, so they did not get the vaccine, you see this exponential rise in the number of cases. And so you saw the headlines, 94, 95% effective. But let me show you the data behind that. When you hear those numbers, they are a point estimate. Let's just take a high-risk group, people over the age of 65. So the point estimate was 86% efficacy. The true value lies somewhere between 61 and 95%. So it is no surprise when you understand the data that at this lower range, there's going to be breakthrough cases, so-called breakthrough cases. And that's true for every category that we look at. Back 20 some odd years ago, I published this paper looking at this phenomena of breakthrough cases because people do not understand this. So we took the number of students immunized at a high school of 2,000 people, okay? And these numbers represent the percent of students that got immunized against the most contagious virus we know of, measles. And then we said, well, that works 95% of the time. So this is the number of students who are immune due to vaccine, the number of students who remain susceptible and who get disease when they're exposed, and the percent of all measles cases that will occur in immunized students. It's a paradox to people. As you increase the number of people you immunize, you will increase the percent of cases that occur in those that are immunized. But you have to look at the data. When we didn't give any vaccine, 2,000 students got disease. When we give everybody vaccine, only 100 get disease. So I hope I've impressed that idea upon you. Now, these vaccines are what are called disease blocking, not so much infection blocking. What that means is if you look at the top part of the graph, without a vaccine, here's the distribution of outcomes of COVID-19. This is just made up data, but to illustrate the point. When you give a disease blocking vaccine like we have, what you're doing essentially is you're out of this number of people who get infected, you increase the number who are asymptomatic and you decrease the number that die or get hospitalized or have severe disease. Unlike on the bottom, a vaccine that prevents disease and infection, where you actually keep about the same number of asymptomatics, but far less of all other cases. So let's look at breakthrough case studies. This is the latest data, just came out a week and a half ago, something like that. This is laboratory confirmed COVID in 99 counties across 14 states in the US, represents 10% of the US population. There were 4,700 hospitalizations just starting to see Delta in the latter part of this study. So this is 4,700 out of 173 million who were fully vaccinated, okay? So that means 1 out of 13,000 in this study would have gone or did go on. The estimate would be to be hospitalized. 20% of them ended up in the ICU. 70% of the hospitalized cases were people over 65. 87% of the deaths were in people over the age of 65. And the fully vaccinated cases who were hospitalized went from 0.01% each month to 16% each month. Remember what I just taught you about the measles case study. We will expect this number to climb and climb and climb as we vaccinate more and more people, for the simple reason the only people left to get disease are people who are vaccinated. It does not mean the popular lay interpretation that the vaccine doesn't work. Breakthrough cases were older, mean age of 73. 71% of them had other complications: diabetes, heart disease, autoimmune disease, obesity, lung disease. And the hospitalization rate was 17-fold higher in the unvaccinated than in the vaccinated persons. Which risk do you want? If you look at cumulative hospitalizations in that study, you see among the unvaccinated, they just keep getting hospitalized. You look at the vaccinated, this teeny accumulation. How about by week? So you can actually look by week. And let's start looking at when Delta variant started circulating. Whoops. You see this starting to take off. How about by age group? 18 to 49, 50 to 64, people over the age of 65. You barely see this line increasing in number of hospitalizations among the vaccinated. A little bit more increase in people age 65 and older. Now look at age alone. Sorry. If you look at age alone, so the orange triangles are people who got vaccinated, then had their antibody level measured. And if you look by age, you see that in general, the antibody level post-vaccination is lower in older people who start accumulating a variety of diseases. We always see this. This is not a surprise. And then you look and you say, well, if we compare antibody levels in people who had breakthrough and people who did not have breakthrough, you see quite profound differences. This is 10 to the 2, 10 to the 3, 10 to the 4. So they're actually big differences, even though these two lines look close together. And that's true whether we look at peri-infection or peak antibody levels. So who should receive additional doses of vaccine? Here's the construct we operate under as vaccinologists. We build immunity very quickly because the population has no antibody, no immunity to this. We've attempted to do that. With time, antibody level falls. We expect that. We know that from seasonal coronavirus. All of you listening to me have been infected multiple times with coronaviruses, seasonal coronaviruses, and we become resusceptible. So you give a booster and it boosts it back up. At some point, you start thinking about what's called a variant focused rather than a late booster. In other words, the variant has sufficiently changed compared to the original one that you actually need to change the type of vaccine you're giving. So let me talk about, there's always cases about breakthrough. Often the questions I get have a bit of an edge to them. You can kind of detect that they are people who had infection and don't want to get a dose of vaccine. What do the data show? So the Kentucky study, and the nature of these studies is they're all retrospective studies, not the strongest study design, but it's the data we have. And if you look at those who were previously infected and not immunized versus those previously infected and immunized, you find about a 2.3-fold reduction in subsequent reinfection. Caution, before really we saw widespread circulation of Delta virus. How about the Chicago study? I show this to you to show the benefit for those of you that might have been infected. And by the way, I would not labor under the false misconception that I got COVID a year ago, so I'm safe against the current and soon to develop variants, would not take that as gospel at all. But those who were previously infected, they had a baseline antibody level on the low side, 620 or so. People who are naive, of course, have no antibody. After one dose, 1,800, look at how those who were previously infected boost. They get a profound boost in their immunity. So why wouldn't you get vaccinated as long as you're eligible? There are other studies. More recently, there's been an Israeli study. If you look at that, particularly what they call Model 3, which most closely approximates our situation, there was a benefit to getting vaccinated. And of course, whether you did or didn't, there's always some breakthrough cases. And what about these boosts? Well, after infection, before vaccination, after vaccination, you see the tremendous boost in antibody, regardless of which variant we're talking about, that occurs in people who have had infection and then get at least one dose of vaccine. As you know, the FDA authorized a third, what's called a late additional dose for people that are immunocompromised. That's about 3% of the US adult population. Recommendation is talk with your healthcare provider to see if you fall under this category and are eligible. Now, very quickly, viral variants, and then we'll start to end here. So this is the green circles as antibody and age. So you see that with time, not with time, with age, antibody levels are lower. They're also lower when you're starting to intersect with different variants. So while the neutralizing ability of your vaccine might be here when you're 60 years old, in the face of the P1 variant, its neutralizing capacity is really down here. So that's why it's important, whether you got a vaccine or previously infected, to have optimal immunity. So if you look at all of the vaccines available, the top 3 here are available in the US, and you look at the different variants, all of those variants have degraded or lead to reduced neutralizing activity, which is why boosters are being discussed, with the exception of Moderna and J&J against the Alpha variant, which is really not the issue anymore, it's Delta. So I'll end this way. We are now in a desperate but unseen and barely noticed race of variant versus vaccine, of ignorance versus knowledge, of disease versus health. And we are very much losing the game. To know, in this case, is science. To believe one knows absent data is simply ignorance. And with that, I will end, and hopefully we have a fair amount of time for questions.
Thank you so much, Dr. Poland. I think we can certainly see why you are considered a foremost expert on this topic. We have lots of questions submitted, and as I said, we had so many that we can't begin to get to them all, but we're going to try and hit on the primary themes of these questions.
Sure.
So the first question I have for you is, can you say for sure that 5 or 10 years from now, we won't discover that COVID vaccines caused harm like neurological problems or infertility?
By definition, you can't answer that question. We have not had 5 or 10 years experience with this. So the only thing we can do is appeal to the science. There is no vaccine whose side effects don't manifest within minutes, to the longest is about 6 weeks. So in the safety studies, the FDA initially said not 6 weeks, you got to follow them for 8 weeks, and then changed it to 6 months. So we're now 6 months to a year, almost a year out now of these issues. We have an extraordinarily robust safety detection or surveillance system here in the US. And other than the known issues, no new ones have popped up, including miscarriage, stillbirth, and pregnancy-related issues.
Okay. A question about kids. Why is there no vaccine for children yet? When might we expect one? And could there potentially be an emergency authorization?
Yeah, I'm smiling. Forgive me. I'm smiling because I had the experience of walking into one room and these two adults, parents, railing on me as to why we don't have a vaccine for kids. I answer it, go to the next room, and the person's saying, why are we rushing the vaccine? So, I mean, again, it tells you the lens that people are looking through. So with kids, appropriately so, the studies take longer. The safety surveillance time period, as I said, was lengthened. But I think we will see an EUA for Pfizer vaccine in the 5 to 11-year-olds by the end of this month, followed, depending on the data, by Moderna and J&J.
Okay, that's good news. Next question. Is it true that vaccines alter your genetic code? Can they rewrite your DNA?
No, they can't. Again, I'm laughing a little bit because this question gets asked every hour of every waking part of my day. I've answered it a million times. And I've sometimes said it this way. I wish we knew how to do that, because there are a lot of diseases that we could cure if we knew how to do it. But the fact is, it doesn't work that way. And it does not change your DNA.
Why is mainstream medicine ignoring cheap and effective treatments for COVID-19 like ivermectin? Why is the medical community only pursuing vaccines?
So this is what I mean by an epistemological lens. That's a question that undoubtedly comes from a viewpoint of conspiratorial or profiteering, kind of suspicion. And I would reject that presupposition because the data allow us to reject that. There's the principal trial, the active 6 trial, and a host of other trials that are in fact studying what are called repurposed drugs, ivermectin being one of them, looking to see if there's any benefit. To date, all of those studies have concluded there is no benefit from ivermectin. And in fact, there is harm in the way the population is acquiring animal ivermectin and using it outside of medical prescription.
There you have it. Let's see, our next question. I've read that the Delta variant is essentially drowning out the latest Mu variant, which is why the Mu variant hasn't spread faster. Is that a reality? Don't we essentially want Delta to continue to thrive in the short term?
No, we don't want any variant to thrive. I think what the questioner is asking is, how come Mu has not outcompeted Delta? But the way it works, think back with Delta. We saw a few months of stuttering numbers of cases, and then boom, an exponential rise. That could happen with Mu. In fact, I'm willing to bet odds that more than likely we will see an increase in Mu. The question is whether we're going to see another variant, which does not yet have a Greek name or letter to it, called C1.2. These are variants that have far more mutations, including the mutations we've seen so far. So these are getting worse, not better. What we don't know is, will they cause worse disease? Will they evade immunity at a greater level than we've seen with alpha, beta, gamma, and delta? We don't know yet until they circulate at wider prevalences.
Another question related to children. If it's rare for children to become seriously ill with COVID-19, why all the fuss about masking in schools? Is there really any benefit, especially among younger kids who aren't likely to wear them correctly?
Yeah, so this is a partial example of the me versus we. when you're in the midst of a pandemic, the larger the number of people you allow to get infected, you drive mutational pressure for worse and worse variants, or at least variants that are different than what the vaccine and monoclonals and convalescent plasma were designed to treat. We've seen that. Some of the monoclonal antibodies now are no longer effective against Delta and were against Alpha. So you're trying to decrease infections for all of us and trying to prevent further mutation. The other thing is, as I explained in my slide, while thankfully kids don't get hospitalized or die at the same rate as us older people, they nonetheless do get hospitalized, do get sick, and do suffer, although probably not at the same rate as adults, so-called long haul symptoms. So for all of those reasons, you're trying to decrease risk. By the way, one of the things that I hear people say is, well, I don't want to take the risk of my child getting myocarditis due to the vaccine. And they don't realize the risk of myocarditis if they get COVID is far higher than the risk of myocarditis from the vaccine, but they don't realize that.
One of our viewers has submitted this question. I want to help contribute to the data. How can I sign up to be a study participant?
Oh, it's very admirable. Thank you to that person. It's really, I would say, on the altruism and sacrifices involved of hundreds of thousands of Americans who have contributed to the data. It's why we know what we know. If you haven't been vaccinated, you might be eligible for one of the remaining trials. Otherwise, it really would wait to a study where you might swab yourself every week, for example, to know how often infections are happening in the community. Or if you were, and I hope you don't, if you were to get infected, there are a number of trials out there looking at these repurposed drugs, monoclonal antibodies, et cetera. And probably the best way that all of us can contribute is being information amplifiers of credible information rather than mis and disinformation. In fact, I would argue, and Paul may want to chip in here, just because Dr. Mueller is nationally known for his expertise in bioethics, I would say that we have some moral obligations here in terms of not giving misinformation and disinformation. And I think, Paul, the AMA and some other societies released a statement about that.
That is correct. And you're right. There are lots of moral implications about pandemics, et cetera. And often what's cited is the right for you to control yourself and what's done to your body. And that is true. But there's a whole realm of public health ethics that's also important. And some of these catchphrases come from that, where right to privacy, for example, ends where public peril begins. And so as doctors, Dr. Poland and I are obligated morally and legally to report, for example, a case of child abuse if we see it, because breaching that confidentiality keeps that child safe. The same is true for elder abuse. It's why we report communicable diseases. We breach that confidentiality to control that infectious disease. And of course, the issue of vaccination and mandates, et cetera, has been tested at the highest court of our land. Now, not everything is legal, is ethical, et cetera, but there's a strong ethical argument for saying that vaccines protect the public and the community, and there's a moral imperative to doing that. And the US Supreme Court first made that statement in Massachusetts versus Jacobson in 1905. No. And Greg has actually spoken on that topic. So while yes, your individual rights are very important, our society is predicated on that. In order to fully manifest those individual rights, we also have to take care of the community. And there's that obligation as well. And that's actually how the court framed it. Yeah. I hope that helps.
Yeah.
That's great. Thank you. A question about monoclonal antibodies. Why did the FDA revoke its emergency use authorization of some monoclonal antibody treatments? If you received these treatments in the past, should you be concerned?
No, they were not revoked because of safety. They were revoked because of the evolving variants. So if you got them, let's just say 8 months ago, there's one set of monoclonal antibodies that now that's been revoked. It worked back when you got it. It doesn't work against the newer variants that are predominating. And for that reason, they revoked the EUA. Not a safety issue.
Good to know. Can you share tips on how we can help diffuse misinformation that others share?
It's, I have the reason I often joke, the reason I don't have any hair is I've torn it out over 40 years trying to discover the reasons behind this. They generally fall. So people don't come to you and say, I'm making my decisions out of fear, or I've been influenced by misinformation. They don't. And so they're not, in some cases, even aware of how they've made the decisions. That's where I think this empathy tool can be valuable. There's rarely a conversation that I can have with a patient to get them to accept vaccines. I liken it, and my daughter, who's a mental health counselor, it really has written a lot about this. It is a journey. It's a journey of trust. It's a journey of information sharing. And in the final analysis, it's a journey where they have to confront the risks and benefits of whatever choice they make. In the context of a pandemic, as Dr. Mueller was just saying, and as evidenced by the president's announcement of his plan yesterday afternoon, I think there is warrant in the face. I don't like mandates myself, frankly, but I think there is warrant for a nation where 1 out of every 500 of its citizens have died of a disease that is controllable with masks and vaccines, to saying we're going to mandate it under certain conditions.
Okay.
May I jump in and ask a question? I'm seeing some of the questions come in, and I just want you to just clarify it for the audience. Kids younger than 12, what's going on in terms of the research? When do we anticipate an approval of a vaccine? And then you might comment on the next phases of vaccines for the new variants.
Yeah, actually, I looked up the dosing just in case somebody was interested. I think I can find it while we're talking here. But what's happening is that I think by the end of this month, that's the best I can discern the internal chatter that's happening from friends of mine at high places. That they will consider and likely grant an EUA for the Pfizer vaccine, hopefully by the end of this month, in kids down to age 5. So I think that's coming. That dose is going to be about 1/3 of the dose that adults get. What's happening simultaneously are clinical trials for kids 6 months to 4 years or 5 years old. And that's going to be 1/10 of the dose of what adults get. So they want to know that it's effective and, of course, that it's safe. In the younger trials down to age 5, they have not seen any unexpected safety issues. So that's good news. And I think that's probably driving the examination of an EUA by the end of this month. And because of, we've done, and let me give you my opinion here, we've done an experiment that I think calls morals into question. We've taken the worst pandemic in the history of any of our lifetimes with the worst variant we've ever seen, outlawed or banned masking, and brought kids together in large groups to see what would happen. Over 1,000 schools have had to stop in-person learning and go online. We have a school district in Florida where 13 of the school workers have already died of COVID just in the last, 3 weeks or so that school started down there. So, we've got some real issues of people not understanding the science. Now, Terry, you mentioned wearing a mask properly. This is true at adult levels too. Proper mask crimps around your nose. So many of the cloth masks don't do that. So there's no air going alongside the nose or around the cheek or under the cheek. It's worn above the nose and below the chin. And I would say a good number, if not the majority of adults, don't always wear it properly, which is sometimes why it's hard in studies to show the value.
Well, this has been such a terrific discussion, but we do want to be mindful of people's time. So I'm afraid we'll need to end our discussion here. I want to thank Dr. Poland and Dr. Mueller for sharing their time and expertise with us today. Our panelists covered a great deal of information, and we'd like to share additional resources that may be helpful. We'll provide this information to our Zoom registrants via email, along with a link to a recording of the presentation. If you're watching us via live stream, please email us at the address on your screen, and we'll be happy to provide you the same information. We invite everyone to reply to that email to share feedback about the event. We'd love to hear from you. Thank you so much for joining us today. Have a great afternoon.